All right, so the calcaneus, you have the routine, which is plantar dorsal axial, and then the lateral. So this is the plantar dorsal axial, and 8 by 10 lengthwise. So the plantar dorsal axial, your central ray is 40 degrees cephalad, so to the heel, as you can see right here, from the long axis of the foot. The central ray is at the base of the third MT, so metatarsal, to emerge posterior to the malleoli. So right here, posterior to the malleoli. So right there, kind of at that calcaneal joint, 40 degrees. So a 40-degree angle. And then to exit posterior right there, so posterior of that malleoli. So the projection actually results in better, this projection actually results in a better visualization of the talocalcaneal joint space. So the dorsal plantar or the weight-bearing coalition right here. So there's several ways to do this, like I talked this morning. It's the same image, it's just different ways of making that image. So this here is 40 degrees. So this is a 40-degree angle. This here they're showing as you're standing up, that's a 45-degree angle. So your angles will change depending on what you're doing. So 45 or over here, the 40 degrees. So this one is coming in on the posterior side of the heel. And then, so this is, you could consider it like a PA image, but it is the dorsal plantar, and then this is a weight bearing. So plantodorsal of the calcaneus, this image here basically comes from this position. So you're visualizing the entire calcaneus, and you can see that calcaneus right here, and you get this joint space coming across. So no rotation, optimal exposure factors, and then that open talocalcaneal joint space. This one is not great, but you still can see some of that joint coming in through there. So that's really what you're looking for. You just want to make sure that you're not clipping the posterior aspect of that calcaneus or clipping that joint space that you're needing. So make sure you watch your collimation. So your axial calcaneal notes the talocalcaneal joint space here, and then this joint space here. So you can kind of see the same joint space right here, and then the same here. So this is dorsal plantar, which the dorsal plantar, if you remember, is this image right here. So the 40-degree plantodorsal. The plantodorsal is this one right here. So this 40-degree. And then this is with a filter. So once again, with a filter, what you're going to do is the thin part of that filter that you will probably never use, this is the heel. So your heel is here, and then your toes are here. So that's how you're getting this good visualization right here. So medial lateral of the lateral calcaneus. So your central ray is inferior to the medial malleolus, so about 1 inch inferior. So your medial malleolus right there, and then about an inch inferior is where your central ray is going to end up. So the calcaneus and talus are visualized. So your calcaneus right here, your talus on top of it. No rotation, optimal exposure factors. Should look like a lateral foot or ankle just collimated to the calcaneus. So you're setting it up just like the lateral foot, just like the lateral ankle. You're just moving your central ray and collimating in on that calcaneus. And then you can visualize that sinus tarsi right there. So ankle routines, you have your routine, which is your AP, also the AP mortise, the 45 oblique medial, plus you can do a lateral if it's part of the 45 oblique lateral rotation if it's part of their protocol, and then just your lateral. 10 by 12 lengthwise for that image receptor, so lengthwise of the long axis of the body part. So your AP ankle, perpendicular midway between the malleoli, so you can visualize your malleoli here and on the other side, and you're going right in to the middle of that. So on the rotation of the foot, you're just going to rotate just a little bit medial, so you put your leg in a true AP position, and then always have them dorsiflex the foot. I always tell the patients, point your toes to the ceiling. You don't want your toes pointed out this way. You want them pointed up towards that ceiling. Okay? So evaluation criteria of your AP ankle, you want a distal third of the tibia. So you've got the distal third of the tibia, distal third of the fibula, and then proximal half of the metatarsals are included, which you can see right here, half of those metatarsals. And then medial and superior aspect of the ankle joint is open. So medial and the superior aspect are open. Okay, so that's the big one for the AP ankle. Medial and superior aspect of that ankle joint is open. So your AP mortise, however you want to call it. So the intermalleolar line is parallel to the IR. So this medial malleolus, lateral malleolus, this is that intermalleolar line, and this is your coronal plane. So it usually sits to where it's not on that coronal plane, so that's why you've got this 15 to 20 degree rotation, and it's the entire leg. So the lower leg is rotated, the foot is rotated as well. So you rotate that lower leg, and then you're going to rotate that foot as well. And then you're going to come down in between, halfway in between this malleoli and this malleoli here, halfway in between those malleoli for that AP mortise joint. And on that mortise joint, the difference between the AP ankle and AP mortise is the entire ankle mortise is open. And you can see that entire joint right there open. Your fibia is not lying into that joint. Your tibia is not closing it up. And that comes with that rotation of that leg, that 15-degree rotation, that 15-degree rotation on the foot. So you're rotating both of those 15 degrees. Distal third of the tib fib, proximal half of the metatarsals, and then optimal exposure factors to visualize the open joint right there. So mortise joint oblique. So this is with proper turning of leg and foot. And then this right here is showing you what happens if you only turn the foot and not the leg. So the foot is turned the foot is turned, but the leg is straight, okay? So you're seeing the mortise joint, but now the fibula is not open, so that joint space isn't completely open. With the proper turning of the leg, you're going to see from the medial side to the lateral side, the entire joint space open. You're going to see that nice tibial plafond right there, and the entire joint. So make sure that you turn that leg and the foot that 15 to 20 degrees to make sure that you open that entire joint. Your AP 45 oblique, so it's a 45 medial rotation. The CR is midway between the malleoli, and then be sure to roll the entire leg and not just the foot. So once again, the entire leg is rolled 45 degrees. You are still at the center between the medial malleoli. Just make sure that this foot is still pointed towards the ceiling, so they're dorsiflexing the toes. You don't want these toes pointed off in this direction, what they call ballerina toes. They're not trying to stand on their tiptoes, so make sure that they pull their toes up. It helps to open that joint and visualize the ankle in that oblique position better. So once again, the evaluation criteria for that 45 oblique ankle, you're trying to visualize that distal tibiofibular joint as far as being open. So this joint right here. So make sure that when they medially rotate, you're going to realize that a lot of patients can't turn that leg in as much. So what you may have to do is support the hip to get that 45 rotation in on that lower leg. So definitely that will open that joint space. Without putting a support, sometimes you're going to get a closed joint space. So really, if that joint space is closed, you haven't created an optimal image for a 45 oblique ankle. You want to make sure you see that joint space when you make that exposure. Once again, the distal third of the tibia fibula, proximal half of the metatarsals, but most importantly, this joint space, that tibiofibular joint, needs to be open. So once again, we did this on the elbow. We'll do it on the knee, do this on the ankle. So you want to make sure that you know what the difference in these images are. So this image here is AP, right? Because our fibular joint our tibiofibular joint is closed. The fibula comes into that tibia. So this is what an AP image is going to look like. This one is your mortise, so that 15 to 20 degree rotation of the ankle and the foot, or the leg and the foot, and you're seeing this entire joint. So if you see a picture where you see this entire joint space open, you know that that is that AP oblique mortise. Okay, so AP oblique mortise. This one here is the 45 rotation. So the leg is turned 45 degrees. You're seeing the tibulofibular joint completely open. The medial malleolus joint is coming closed, but your tibiofibular joint is completely open. And that's when you know you have your AP oblique ankle joint. So AP ankle, so AP ankle, your 15 to 20 degree AP oblique mortise joint, and your 45 oblique ankle medial rotation. Okay? So your lateral ankle, your central ray is centered to the medial malleolus. So right there, medial or lateral malleoli is where you're going to center. So medial is the medial malleoli, the lateral medial is the lateral malleoli. The only thing I don't like with this image is this foot shouldn't be down this way. It should be out this way. So dorsiflex that foot just like this one is dorsiflexed. Okay? So make sure you dorsiflex that foot. The lateral medial is harder to hold in that position, so that's why we normally do the medial lateral position. Your evaluation criteria, you want the entire talus and calcaneus visualized. So you have your entire calcaneus and your talus visualized. Lateral malleoli are superimposed over the posterior half of the tibia. So here's your tibia, your medial and lateral malleoli right there. So that is positioned over the posterior half of that fibula, okay? And then optimal exposure factors. And you should still be able to see this really nice sinus tarsi right there. So AP oblique, midway between the malleoli. CR is perpendicular to the long axis of the foot. A normal position for a patient, they're going to have to rotate their leg, their foot in about 5 degrees, maybe 5 to 10 degrees to get a true AP position. Your AP mortise, that's when you're rotating the leg and the foot 15 to 20 degrees medially to open up the mortise joint. And then your lateral, like I said, I don't like the foot like this, pointing down. You want to dorsiflex so your toes are pointing up. That's going to make for a way better picture. If the patient can, you don't want to force it. You just want them to do as much as they can. See, central ray is to the lateral malleolus. Your stress, so inversion and eversion. Inversion is medial, eversion is lateral. So there's stress tests. It's for the joint separation and ligament tear or rupture. You can see that they are wearing leaded gloves and holding that foot in that position as the patient's not going to be able to hold that foot, and you need a little bit of stress on there because they are stress images. So a patient's not going to be able to do it on their own. Evaluation criteria, so the distal aspect of the tibia fibula demonstrated, so you need to see the distal aspect of tibia and fibula. Ankle joint centered to the image, which it is centered to the image, and then optimal exposure factors, and you want the inversion and the eversion, not on the same image receptor, but in the same imaging packet, so the radiologist can see both pictures. You can also note it if you want to, which one is which. You're just going to annotate it on that image, so it goes across to the radiologist and they know what they're looking at. So we're going to move now to the lower leg, the tib fib. When you're doing a tib fib, it's an AP and a lateral. You can see here that this image receptor is diagonal, and you can do that. What you're going to want to do is make sure and check first to see if the tib fib will fit in the long axis of the image receptor. Keep in mind you need ankle joint and you need the joint of the knee in the image to make your tib fib. So you're either going to do them on a diagonal or full length of that image receptor, or you're going to do two. You're going to do a lower and an upper. Just depends. So 14 by 17 definitely lengthwise or diagonal. So central ray is your foot, your leg is in a true AP position. Keep in mind that that may be about 5 degrees rotated in, and you'll be able to tell the ridge on the tibia as far as being centered in a true AP position. So turn IR diagonal and or increase SID to fit more of the leg on the image receptor. So it's usually at a 40 SID, but what they're talking about here is that you can increase your SID, say 45 or 50, and that will allow you to capture more of the leg on the image receptor without having to turn it diagonal. So your SID can be played with a little bit, just depending on what you want to do and how their leg is going to fit on there, or you can also turn it diagonal. So your evaluation criteria, you can see here that we've got the ankle joint and the knee joint. Okay, so entire tib fib demonstrated, knee and ankle joint demonstrated, partial superimposition of the fibula and tibia at the proximal and distal ends. So you're going to get tibia and fibula superimposed there, and tibia and fibula superimposed there on your AP image, and that is what you are looking for. So the lateral is usually a medial lateral leg. There's two different ways that you can do this. You can do it with this leg in front, or you can bring this leg here and it can cross over and come up here in front, just as long as you keep this leg in a true lateral position. So if both joints don't fit on the IR, use a second smaller IR for the unaffected joint, which is either you image high to include the knee, and then you're going to use a smaller image receptor for the ankle and the distal tib fib, or you do the ankle and distal tib fib and then pick up the proximal tib fib with the knee joint to finish off the two images of the lower leg. So your evaluation criteria, you need to have your ankle joint and your knee joint, and you can tell that this is a child because the epiphyseal plates are not fully formed, so it's a shorter leg and it'll definitely fit on one image. Entire tib fib demonstrated, knee and ankle joints are demonstrated. Proximal head of fibula superimposed by tibia, so proximal head superimposed by fibula, and then superimposed by the tibia, and then the distal fibula is superimposed over the posterior half right there of the tibia, and then optimal exposure factors. So AP and lateral lower leg. This leg needs to be rolled in just a little bit because it's not in a true AP position. You can see that there's a little bit of an angle there that they're using, and what you want is you want a 0 degree, so definitely roll that leg in so it's in a true AP position, and then you're at a 0 degree. Include both joints, central ray parallel to the long axis of the foot, CR horizontal to the mid shaft, so you want it to the mid shaft. Include the knee joint, which they are picking up the knee joint, and the ankle joint, which they are. Once again, even on the lower leg, point the toes to the ceiling. It makes for a better picture of that ankle joint that needs to be included. So I'm going to end right there, and then we will pick up the knee on the next lecture. I'll go ahead and post this, and then we'll come back to another one.